clinical study which is entitled "Should Parenteral Nutrition for Preterm Infant be Photoprotected?" This study is the result of collaboration between Canadian, French, and Egyptian teams. To introduce the subject, I will speak to you a little about preterm infants. Preterm infants, compared to fetus, have a high oxidant load due to oxygen exposure, transfusion sometimes, sepsis when it happens, and to parenteral nutrition. Parenteral nutrition contain oxidants, and we will see that a little later. And these preterm infants have weak antioxidant systems due to their immaturity and due to low maternal milk, due to the immaturity of their gut. They can't tolerate important quantity of maternal milk. Maternal milk has antioxidant properties. This preterm infant has an imbalance between weak antioxidant system and high oxidant load. Light-induced oxidation and peroxidation of parenteral nutrition solutions. It has been demonstrated by Nursing in 1995. And multivitamin solution are the main source of peroxide in parenteral nutrition solution. Peroxides at the concentration in which they are found in parenteral nutrition for preterm infant when exposed to light are cytotoxic and bactericide in vitro. Photoprotection of parenteral nutrition solution has been demonstrated to decrease the peroxide contents of parenteral nutrition as biochemical benefits, and it has been demonstrated that the infants who receive parenteral nutrition photoprotected have lower contents of oxidant markers in their urines, have nutritional benefits with an increase in enteral feeding when parenteral nutrition is photoprotected, as histological benefits in an animal models. In guinea pigs who received photoprotected parenteral nutrition, the side of the pulmonary alveoles are smaller than in animals receiving exposed parenteral nutrition. The first large-scale study which addressed the question of bronchopulmonary dysplasia or death in very low birth weight infants when photoprotected is from last year, and has shown no effect on bronchopulmonary dysplasia or death of photoprotecting parenteral nutrition solutions. Our hypothesis is that for some preterm infants, death is induced by the imbalance between the oxidant load and the antioxidant defenses. Photoprotection may decrease mortality in these very low birth weight infants by decreasing the oxidant loads of those tiny infants. The aim of the study was to evaluate the consequences of photoprotection of parenteral nutrition solutions on mortality of very low birth weight infants. We performed a meta-analysis. The identification of eligible trials was done through electronic databases. The selection criteria choice were premature infants, newborns, total parenteral nutrition, photoprotection, clinical trials, mortality, and death. And a meta-analysis was performed of mortality data at 36-week gestational age or at hospital discharge. 34 publications were identified. 70 titles was excluded due to the absence of relevance. 17 abstracts were examined. 5 reviews were excluded. 12 studies were assessed. 7 titles was excluded due to multiple publications from the same population. 5 studies were obtained. 1 title was excluded due to the absence of randomization. 4 publications were included in the meta-analysis. All the studies which were published between 2007 and 2014 were randomized studies. The sample size was from 56 infants to 587 infants. The gender was male for 50 to 56%, which is the normal in this population. The gestational age of the infants ranged from 27 till 31 gestational age for the mean in each study. And the birth weight ranged from 775 grams till 1,588 grams. The number of days of total parenteral nutrition ranged from 9 to 11, and for one study was not given. And we only had the number of days of parenteral nutrition, which is 28 days for the mean. Mechanical ventilation was performed in 66% till 82%. The mortality at 36 weeks gestational age ranged from 5 till 32%, depending on the study. Here you have the results in the light-exposed group and light-protected group. When you look at the total of the infants which are dead, it's 52 in the light-exposed group, with 359 in the alive, and in the light-protected group, it's only 28 infants which are dead, with 361 which are alive, which is a very important decrease in the mortality in the photoprotected group. When you look at the results of the meta-analysis, you can see that the odds ratio for for death is divided by 2 with odds ratio which is at 0.53, with a confidence interval between 0.32 till 0.87, and it's significant with a p below 0.01. And the heterogeneity is at 0%. All the study give the same kind of results, even if none was significant by itself. The mortality is divided by 2 in the study. It's a huge decrease in the mortality rate among very tiny babies. The mechanism that can be implicated may be the balance oxidant antioxidant that can be due to the fact that photoprotecting parenteral nutrition solution decrease the oxidant load. It may be also the bioavailability of nutrients and vitamins in the photoprotected solution, which are better. It can also be a direct toxicity of one of the components, which are due to oxidation of parenteral nutrition. The limitation of the study that we don't have any idea of the long-term outcome of the survivors, which was not studied in any of the study of the meta-analysis. This study results are in opposite with the Sherlock study, which is a cohort study. Sherlock study used partial photoprotection, and all the study include use complete photoprotection. Complete photoprotection is more efficient in decreasing the oxidant load, but it's quite complex and you can see here what was used. You need syringe, which are amber, and tubings, which are yellow, and it's quite complicated, and it has to be done in pharmacy when parenteral nutrition is made, and it has to be till the baby. And you can ask the question of feasibility for large-scale clinical use. Our conclusion is still, is it ethical now to infuse unprotected parenteral nutrition solutions to the most immature preterm infant, knowing that when you photoprotect the solution, the mortality is divided by 2. And what happened in other populations with compromised oxidant-antioxidant balance, and in which parenteral nutrition is also exposed to light. And the perspective is, can we find a way to minimize the infused oxidant load, which is less time consuming and less expensive than photoprotecting all parenteral nutrition? And can we optimize the antioxidant defenses of the most immature preterm infants? Thank you for your attention.